I'm also feel very happy to share with all of you that today we are into 50th session of continuous academic series since the last 49 months. So on this special webinar, today we have with us a senior anesthesiologist, most eminent national as well as international speaker, Dr. J V Divatia sir with us. Sir will be speaking on the most challenging, though not very frequent, that is the major adverse cardiac events after non-cardiac surgery. I feel sir doesn't require any introduction, but as a customary, I take the privilege to introduce sir. Presently, sir is a head of the critical care unit in Leelavati Hospital and Research Center, Mumbai. Sir has served as a former professor and head of the Department of Anesthesiology, Critical Care and Pain, Tata Memorial Hospital, Mumbai. He has been a vice chancellor for the College of Indian Society of Anesthesiologists, and he has been an editor-in-chief for the Indian Journal of Critical Care Medicine, Airway Journal, and Indian Journal of Anesthesia. Sir was the past president for ISA, National, as well as Indian Society of Critical Care Medicine. Sir has around 210 publications in national as well as international journals. So with this brief introduction, I would like to welcome Dr. Divatia, sir. So welcome you, sir, for today's webinar.
Good evening.
And I would like to request Divatia, sir, to proceed with his talk. So you can proceed, sir.
Good evening. Thank you very much for inviting me to speak here. And congratulations to Ballari Anesthesia Society and WIMS Anesthesia alumni for conducting 50 academic programs and to speak at this very prestigious 50th landmark event for you. So thank you very much for inviting me to this particular episode. And I'm really delighted to be here with you. And in any case, it is very difficult to refuse an invitation when Dr. Balavaskar and Dr. Srinivas make to you. So thank you so much once again. So let me move on to my talk. And this is going to be on major adverse cardiac events. Okay. And this is in the setting of non-cardiac surgery. I hope you can see me, and I hope you can hear me well and see my slides.
Yes, sir.
Yes, sir.
So almost all that I'm going to speak to you, and for those of you who want to refer more in detail to what I'm going to speak about, this is based largely on the guidelines for cardiovascular management following for non-cardiac surgery, which were published recently by the AHA. Okay. So what do you mean by a major adverse cardiac event, perioperative major adverse cardiac event? It's an event that occurs within 30 days following surgery. Okay. And it occurs in about 3% of patients undergoing non-cardiac surgery and 1/3 of deaths at 30 days. So it is a fairly common problem, but it is also a very significant problem because of mortality. A lot of patients who die within 30 days, about 30% of those who die die because of a major adverse cardiac event. And essentially, what is a major adverse cardiac event? It is either exacerbation or worsening of pre-existing cardiovascular disease, that is one category, or new occurrence of ischemic heart disease, arrhythmias, heart failure. It also includes stroke and transient ischemic attack, and of course, cardiac arrest and death, right? So in simple terms, it's either a worsening of an old cardiac problem or a new cardiac problem that occurs within 30 days after surgery. Very importantly, we are now recognizing another new sort of form of a major adverse cardiac event, and which is called as myocardial injury after non-cardiac surgery, or MINS. And this has been possible to detect because more and more people are measuring troponin levels after highly sensitive troponin levels after non-cardiac surgery. And it has been seen that almost 20% of patients have an elevated troponin level, a significantly elevated troponin level. And while the patient may or may not be symptomatic, a high troponin level in the perioperative period is associated with a higher incidence of cardiovascular disease and cardiovascular complications later on in life as well. Okay, so either a high troponin level or an increase in troponin levels in the perioperative period, a serially increasing level, also are now considered as a major adverse cardiac event, and it is goes by the acronym of MINS, so myocardial injury after non-cardiac surgery. And this is not a myocardial infarction. You will not get the ECG changes and so on, but you will get elevation of troponin levels. Now, before we go on, these are the standard definitions which we need to be aware of and to define the different types of surgery. So, of course, we know what is emergency surgery, urgent surgery, time sensitive, is like cancer surgery, elective surgery. Now, the most important definition we need to know is what is a high risk procedure and what is a low risk procedure, right? So, a low risk procedure is one where the incidence of a MACE is less than 1%. And that is because of either surgical characteristics or patient characteristics, where the predicted risk of MACE is less than 1%. And an elevated risk is where the risk of MACE is more than or equal to 1%. So 1% is a cutoff for a definition for high risk and low risk surgery. And how do you define, how do you understand what is a low risk, high risk surgery is a little bit of what I'm going to talk about. Now, we also need to keep in mind that, while we are anesthesiologists and we are interacting with surgeons, when you're dealing with these patients who got a high risk of MACE or who've got cardiac problems, then, the team approach is the best approach, right? And we need to make sure we work together as a team in all these patients with cardiovascular disease. So I'm giving you two patients. So this is a 70-year-old male who's planned for a hemicolectomy for colon cancer. He's a hypertensive, which is well controlled. He's a heavy smoker for 50 years. Effort tolerance appears to be good. He's got a normal ECG and physical examination. So do you think he's at high risk or low risk? Yeah. And I'm sure most of you would say that, apart from age and a little bit of smoking and hypertension, it doesn't appear to be a very high risk candidate. And that's just our initial impression of when we sort of are presented with a history like this. This is another patient who's a 75-year-old male who's planned for a Whipple's procedure. Uh, he's a smoker. He's had a myocardial infarction 5 years ago. He's diabetic. Because he's got peripheral vascular disease, he's not able to walk, and therefore we are not able to estimate his effort tolerance. He is on multiple cardiac drugs like aspirin, digoxin, ACE inhibitors, and insulin. The ECG appears to be normal, but his creatinine is 2. Now, again, when you just look at this history, you're dealing with a high-risk patient. But what is really now advocated is you should be able to quantify the risk, right? And we should be able to quantify risk using a validated risk prediction tool. In other words, a tool which has been uh, developed and assessed in large populations, and we know that we have some good idea of how useful or what is the predictive ability of this tool. Right? So a validated risk prediction tool is extremely important to estimate the risk of perioperative MACE. Right? Now, one of the important components of risk prediction is the assessment of the functional status of the patient. Right? So if you're undergoing an elevated risk non-cardiac surgery, you should have a structural assessment of the functional capacity. And again, you need a validated tool, such as now in this case, the Duke Activity Status Index, to risk stratify the risk of perioperative MACE. So in other words, we are moving away from subjective sort of estimates of high risk, low risk to validated tools, which also give you a reasonable quantification of the magnitude of risk. Now, one of the most popular and the oldest tools to risk stratify patients with cardiovascular disease is the Lees Revised Cardiac Index, or the RCI, the Lees Revised Cardiac Index. And now here it considers six risk factors. So one is a high risk surgery. So that's a surgical risk factor. So any intrathoracic, intraperitoneal, or suprainguinal vascular reconstruction becomes a high risk surgical procedure. History of ischemic heart disease, history of congestive cardiac failure, history of stroke or TI, insulin-dependent diabetes, and a creatinine more than 2 milligrams. These are the six risk factors, okay? Now, if you have less 0 or 1, that is less than 2 risk factors, your event rate is 0.9%, which by earlier definition, we said is a low risk of MACE. But if you've got 2 or more risk factors, then your risk is quite high. In fact, if you've got 3 or more risk factors, the risk of having MACE is 11%, which means more than 10% of such patients with 3 or more risk factors will have a major adverse cardiac event after non-cardiac surgery. Right? So this is an extremely high risk sort of thing. So this is a simple way. By just looking at certain 6 risk factors, whether they're present or absent, you can quantify, and there is data to support this sort of risk over here. More recently, what has happened is, they've developed a risk stratification tool based on a large patient database. So this is a prospective database from the American College of Surgeons. It's called the National Safety and Quality Improvement Project. And this was based on over 2 lakh patients from 250 hospitals. Out of these, just about 0.65 developed a myocardial infarction, postoperative myocardial infarction, or cardiac arrest. And they found, these were the sort of predictors of post-op myocardial infarction or cardiac arrest. And this was a type of surgery. Functional status was a dependent. So if a patient needed assistance for his activities of daily living, abnormal creatinine, ASA class, and increasing age. And based on these 5 risk factors, they have designed a score, which is called the Gupta Perioperative Cardiac Risk Score. And again, it puts all these things in. And there are very nice calculators. If you go to MedCalc or any Medscape or any of these risk calculators on the net or on your phone, you will get these parameters, and it will give you what is the risk of this patient. So if you type these numbers in, then you will get what is the risk of a MACE. And this model works better than the Lee's revised cardiac index. And this is what is one of the scores which is recommended to estimate whether this is a high risk. This patient is undergoing this particular procedure, is at high risk of MACE or at low risk of MACE. Okay. There's another sort of score which is now being used, which is called the American University of Beirut HAS2 score. And again, it's based on very simple things like age, history of heart disease, angina, hemoglobin, and whether it's a vascular or emergency surgery. So now if you once we know that these are the tools to risk stratify these patients, let's look at our patients again. So this is the first patient. So he in fact has none of the risk factors for on Lee's revised cardiac risk index, and his score is very low risk. And if you look at the Gupta score, if you put in all these parameters, then the risk of MACE is only 0.28%. So this is so this tells you that this patient at low risk of MACE. On the other hand, look at the second patient, right? He's 75 years. If we put all these things, he's got at least 4 risk factors, and maybe CCF because he's also taking digoxin and an insulin inhibitor. Maybe he's had CCF, but at least 4 risk factors. And the presence of 4 risk factors tells you that his risk is more than 11%, right? And if you put the same numbers into the Gupta cardiac risk index, we find that he's got a 5.6% risk of suffering a MACE. So this patient is at a very high risk, and this is based on a validated quantification from a risk assessment tool. Now, please remember, this is for this assessment that we talked about is not for patients who've got severe valvular heart disease or severe pulmonary hypertension or congenital heart disease, which are risk factors in their own right? And the presence of any one of these actually increases the risk or has a different way of tackling these patients. So this is for patients without all these sort of things. Okay. So now the next question is that you risk stratified and you got some idea of the risk. So how do we go about this? Do we need to do further investigations, and what all do we need to do to further evaluate the risk, and what can we do to reduce the risk, right? So what further tests would we do? So one is for a low risk patient, and the second is for this high risk patient. Okay. One of the first things that you do when you look at the cardiovascular system is ECG before non-cardiac surgery. And again, the guidelines tell you that asymptomatic procedures undergoing low risk procedures do not need an ECG. Now, our hemicolectomy will come under this. Asymptomatic patients undergoing elevated risk procedures without cardiovascular surgery, he probably is okay for an ECG. And of course, if there is any ECG which is showing abnormalities, obviously going to do a repeat ECG. Okay, so this patient, you would probably do an ECG. What is new and what is now recommended is the use of cardiac biomarkers to further risk stratify these patients. So in these patients who've been classified as elevated risk, which is a risk of MACE more than 1%, that is patients who have known cardiovascular disease, age more than 65 or age more than 45 with symptoms of cardiovascular disease, you should do a N-terminal pro-BNP and a cardiac troponin level. And elevated levels of these signify that this patient is at higher risk. Okay, so and the troponin level serves as a baseline then for estimations in the postoperative period. And a rising troponin level, like I mentioned, can suggest that this patient is likely to experience some problem. Echocardiography, very popular investigation. What do the guidelines say? Now, okay, so again, asymptomatic and clinically stable patients probably don't need a echo. If you have a known diagnosis of heart failure with worsening dyspnea or change in clinical status, definitely. And of course, if you've got new findings or new symptoms, you should be doing an echo. Okay, so there is some scope of doing echo in many patients. A lot of us, we come across patients who an echo has not been done, and then you see the patient on the table and you see that, oh no, the ECG is not right, and maybe the patient, then, maybe we should do an echo, and we do a POCUS, point of care ultrasound on the table, because many of us are now reasonably okay at doing echoes, at least gross screening for gross abnormalities in the heart. Now, the guidelines do not say anything about POCUS simply because the data is not there. So whether the POCUS done on table by an anesthesiologist is as good as or non-inferior to echoes done by cardiologists in the clinic, we don't have much data on that, and that is why we sort of there's no recommendation on this, though sometimes some of us do this. We see, if we have a doubt, we just do a quick echo, a screening echo, and if we find more or less okay, we sort of go ahead. When should we do a stress test? Okay, so the stress test should only be done in patients undergoing elevated risk non-cardiac surgery with poor or unknown functional capacity and elevated risk for MACE. And I think our second candidate fits that bill, isn't it? Because he's got elevated risk non-cardiac surgery and Whipple's. His functional capacity is unknown because he's not, he has a peripheral vascular disease, and we don't know his functional capacity. And of course, he had elevated risk of MACE based on the Gupta score. Right? In most other patients, there is almost no need to do a stress test. Okay? The guidelines are again silent on cardiopulmonary exercise testing or CPET, again, because there is no data on the predictive value of CPET for cardiac complications. There is more data in patients who got pulmonary disease and, from risk stratification of thoracic surgery. There does not appear to be as much data on CPET for risk stratification for cardiovascular disease. But otherwise, I mean, many would use data from the CPET to also include it in your risk stratification, but these guidelines do not give you any definite clue in this. So if you look at our further tests for our two patients, our low risk patient probably does not need anything. Okay. But the 75-year-old male undergoing Whipple's with so many issues, okay, and a high risk of MACE will require an ECG, probably an echo, should definitely get an pro-BNP and a troponin level, and possibly, and also a stress test. Which type of stress test will depend on the condition of the patient. And this fellow can't walk, so obviously he's not going to undergo a treadmill test, but he'll probably undergo a dobutamine stress test or a pharmacological, some kind of pharmacological stress test. Now, once you know that the patient is at risk, what can we do? And in most patients who've got ischemic heart disease, the question is, should we do coronary angiography, right? And if you're doing a coronary angiogram, the logical next question to ask is, should we do revascularization if there is significant coronary artery disease? Okay. So what do the guidelines say? So in patients undergoing elevated risk surgery with poor or unknown functional capacity and high risk for MACE, you can do a coronary CT angio, right? So coronary CT angio is recommended for some patients. Okay, invasive coronary angiography is not routinely recommended, and there are specific indications in which patients should get a invasive coronary angiography in the preoperative period as part of the pre-op evaluation. And the indications for preoperative invasive coronary angiography are probably similar to those which you would require to do in the non-operative setting. And that would be a patient who's getting acute coronary syndrome, someone who's getting worsening of angina, okay, on someone who's got first newly diagnosed ischemia on moderate or severe ischemia on stress testing, and if your ECG suggests left main coronary artery disease. Okay. So who should be considered for preoperative vascularization? Obviously, patients with acute coronary syndrome. If a patient has acute coronary syndrome, right, which means unstable angina, STEMI or a non-STEMI, then these patients are not fit or not candidates for elective non-cardiac surgery, and these patients should go in for coronary artery revascularization. Obviously, you're going to postpone the surgery and go in for revascularization. Uh, you can consider revascularization prior to major non-cardiac surgery if your patient has chronic coronary artery disease and hemodynamically significant left main artery stenosis. If you've got left main coronary artery stenosis, then probably you may want to consider revascularization. In all other circumstances, if you don't have left main disease, you do not need to revascularize the patient just because there are some blocks in some other vessels. Okay, so in those cases, you do not need to do a coronary angiogram and revascularization. But revascularization is required if the patient has an ACS, in which case you're going to postpone the surgery and do an angiogram and revascularization, or if you've got clinically significant left main coronary artery disease. Now, in the past, we used to say that, oh, if you're going to do surgery in the near future, you should maybe just do a dilatation, or maybe you should put a bare metal stent or something. But now, the new generation drug-eluting stents are preferred across the board for at any point in time. Okay, so in this day and age, if you're going to do a stent, then you are going to use one of the modern drug-eluting stents because these have superior outcomes as compared to bare metal stents. Okay? So there's no question that the outcomes with drug-eluting stents in the long run are far superior to those of bare metal stents. Okay? The problem, as we all know, is that after putting in a stent, especially the drug-eluting stent, you have to delay time-sensitive non-cardiac surgery because you need time for endothelialization of the stent. Until that happens, you're going to give this patient massive dual antiplatelet therapy. And dual antiplatelet therapy increases the risk of bleeding, makes non-cardiac major cardiac surgery risky, and therefore it is recommended you do not do major non-cardiac surgery after stent is in while you're giving high doses of dual antiplatelet therapy. Now, the question is what is the minimum duration for which you should give dual antiplatelet therapy? Now, dual antiplatelet therapy is given for a long period of time earlier, and you should defer surgery for that period. Earlier, it used to be 1 year, then we came down to 6 months. We've come down to 3 months in some cases, and the minimum safe interval for giving dual antiplatelet therapy and not doing surgery in that period is now come down to 1 month. But 1 month is the bare minimum, and only in exceptional situations should you attempt surgery, because when you're doing surgery, you're going to have to cut out one of the antiplatelet agents. So you must make sure you've given dual antiplatelet therapy for at least 1 month, probably 3 months, hopefully 6 months, right, before you can cut down one antiplatelet agent. Okay. So this is the sort of way of looking at the optimal timing for elective or time-sensitive non-cardiac surgery in patients requiring DAPT after a stent. Okay, now we are not going to look at balloon angioplasty or bare metal stent because now we only say we should be using drug-eluting stents, right? So if you had a drug-eluting stent put in for an acute coronary syndrome, then there is no question you should try and delay for at least 12 months. So if you had a stent put in for an acute coronary syndrome, try and delay surgery for 1 year. Otherwise, at least more than 3 months if you got a time-sensitive surgery like cancer. So after an acute coronary syndrome, and you get a stent, you should. So after a bare metal stent, after a drug-eluting stent for acute coronary syndrome, you must delay for at least 3 months and never for less than 1 month. Okay. If you had a stent in for coronary artery disease, which is not an acute coronary artery syndrome, you can delay for 6 months, not 12 months, but 6 months is ideal. Otherwise, 3 months if you got a time-sensitive surgery, and definitely not less than 1 month. After this period, you can cut out one antiplatelet agent, which is usually clopidogrel. Now, in all these patients, right, who had a drug-eluting stent, especially after acute coronary syndrome, very commonly what nowadays being used is ticagrelor along with aspirin, okay, or prasugrel along with aspirin. Or clopidogrel along with aspirin. So if you're using ticagrelor, it has to be withheld for 3 to 5 days, clopidogrel for 5 days, and prasugrel has to be withheld for 7 days before non-cardiac surgery, and while you continue aspirin. And this is to protect in-stent thrombosis, which occurs early after insertion of a stent. There are a few patients who, after a percutaneous coronary intervention, they have a high thrombotic risk. But you also need to do surgery, right, in less than 6 months, in which case, you can do what you call as bridging with an intravenous antiplatelet agent. So you continue aspirin throughout, okay? Then you stop your prasugrel, you stop your topical ticagrelor, and then at that point you start a cangrelor. Cangrelor is also like ticagrelor, but it is an intravenously available agent, and you can give cangrelor, stop it 6 hours prior to surgery, do the surgery, resume cangrelor about 6 hours after surgery, when you're sort of within 1 hour after surgery, once you're reasonably sure of hemostasis, and then you can restart clopidogrel. Okay, so you can do bridging with the antiplatelet agent in very high risk patients. If you're forced to do it, say between 1 and 3 months after a stent, you can use bridging with clopidogrel. Okay, so remember now there are many sort of options available, and it's with consultation with the cardiologist and maybe the hematologist, and of course the surgeon and us, we can sort of devise which is the best way to go about a particular patient who's at high risk, both for a coronary syndrome, for surgery, who needs a surgery, and who also has a stent and a high risk of in-stent thrombosis. So it becomes a multidisciplinary sort of thing, and sometimes you might need to assess the platelet function before you make your final decision. Okay. If there's hypertension, you can postpone, but most people will not postpone unless the BP is really very high. What about other drugs? So of course you need to continue beta blockers if they've been taking them chronically. Okay. And if you have to initiate beta blockers and you have time, you should initiate beta blockers for a week to 10 days before surgery so that you can titrate the dose well and you can make sure that there are no complications from beta blockers. Okay. So they should prefer atenolol or bisoprolol rather than any other beta blockers. But irrespective of that, make sure your BP remains above 100 and your heart rate is somewhere between 60 and 70. Okay, so that you don't give too much of a beta blocker and create complications, as was noticed in the POISE trial. Now, all these drugs we are all very quite familiar with. Statin should be continued. Renin-angiotensin receptor antagonists should be stopped if they are given for hypertension. But if the patient has been given these drugs for heart failure with reduced ejection fraction, maybe you can continue. Of course, there is a risk of hypotension, but then we have to weigh the risk of decompensation of heart failure versus risk of hypotension during anesthesia. SGLT2 inhibitors, the flozins, right, the dapagliflozin, empagliflozin, these are anti-diabetic agents, but they are being extensively used today because in diabetics with heart failure, especially heart failure with preserved ejection fraction, diabetics with with chronic kidney disease, the flozins, the SGLT2 inhibitors actually improve outcomes. So diabetologists, nephrologists and cardiologists, they like these agents. And many patients today are on these SGLT2 inhibitors. The problem is they cause, one of the side effects is a euglycemic ketoacidosis. And in order to avoid that complication, you should discontinue these agents for 3 to 4 days prior to surgery. Okay, but otherwise they are very good drugs. But because they have this problem of euglycemic ketoacidosis, it is probably better to stop these agents prior to surgery. Of course, you should treat anemia. IV iron preparations are extremely useful for this, and tranexamic acid to given blood loss may be tried. Now, during anesthesia, there is no particular technique, but at the end of the day, you have to maintain the myocardial oxygen balance during anesthesia and surgery. So you should avoid things which decrease the coronary blood flow, such as tachycardia, hypertension, and increased preload. You also need to avoid factors which increase demand. Again, tachycardia. So tachycardia is bad both for decreasing blood flow as well as increasing demand. So tachycardia is very bad. Can you just excuse me for a minute? Hello? Hello? Actually, yeah, exams. Okay, so I think I've got a slight emergency. I'll wind up quickly. So you need to do this sort of thing. Okay. Okay, there's no difference in the type of anesthetic. So although a lot of us are regional anesthesia enthusiasts, randomized controlled trials have not shown any difference between regional versus general anesthesia. You should maintain the blood pressure at a constant level, by rather than waiting for hypotension and giving epidural bolus, you should give maybe a NORAD infusion to maintain a constant blood pressure. Okay. Do not use routine pulmonary artery catheterization or IV NTG or TE only for selected cases. And post-op, of course, you're going to do ECG and look for symptoms, but very importantly, you should do a troponin level in these patients. And those who have higher troponin levels are at higher risk of post-op complications. So I think I've covered a lot of things, but there are areas which I have not covered, which are very specific things like atrial fibrillation, anticoagulation, aortic stenosis, and management of postoperative myocardial infarction. So thank you for listening, and I can take some questions. And if you will please excuse me, I have to go to attend to an emergency, and I'll get back to you. Okay? So I can take questions while I'm going to the ward on the phone.
Yeah. Any questions, Parimala there?
Yes, sir. Thank you, sir. Thanks a lot. I don't know any queries in the chat box, sir. Uh, so from my side, actually, I want to have some clarification regarding the angiotensin receptor blockers, sir. The peri-op, whether to continue, like as you said, sir, they are to be discontinued. Whether it depends on the type of anesthesia, type of surgery, then the hypertensive stage, and as well as when to stop, sir. Any fixed guidelines for stopping these ARBs, sir?
So 24 hours prior to surgery, if you want to stop, you can stop. Okay.
Okay, sir.
And if it's for heart failure and you feel if the
There is also a question, by Dr. Gurudhar.
the risk benefit ratio is in continuing, we should continue the risk. Yeah.
Okay, sir.
But if it's for simple hypertension or something, we can always.
So after stopping, do we need to bridge with the other antihypertensives, sir?
Yeah, so you can give some other antihypertensive to control the blood pressure, and maybe something like amlodipine or a calcium channel blocker can be given. Okay, or a beta blocker
if it is already in existence, but not don't start a new beta blocker.
Okay, sir. Okay, sir. Thank you, sir. So there's a question by Gurudat sir. If the patient is bridged with congrular, what about central neuraxial block use? Hello, sir.
Yeah, he had a call. Okay, we'll see if he can join.
Okay, sir.
So, but there was this discussion about the congrular when we spoke about ticagrelor and congrular as an IV preparation. Guru sir, you are online here? Yeah. So, Divatia sir, there was this question on the usage of congrular and a central neuraxial block. If we can take, it's okay. Otherwise, we can collect all the questions and get in touch with you.
Hello, can you hear me, madam?
Yes, sir. Yes, sir. We can hear you, sir.
If the patient on congrular, please not use central neuraxial block. Huh?
Okay, sir.
No, even after stopping for 6 hours, because you said congrular has to be stopped for 6 hours.
अकरा urgent जायचे. हाँ चल. Hello. Hello. कौन सा मशीन आ रहा है? उनके लिए. कौन सा मशीन आ रहा है? मशीन आ रहा है. तो मैं भी आ रहा है. Hello.
Yes, sir.
Hello, sir. Sir.
Yeah. So did you hear that? Or congrular, please do not use neuraxial block.
No,
Yes,
because
I got it.
congrular
anesthesia.
duration of action of congrular is 90 minutes maximum.
Yeah, but you're going to
So
bridge
since you are
afterwards
stopping
with,
for 6 hours.
No, you're stopping congrular only for 1 hour, and then you're bridging. Then you are going to restart your clopidogrel. So you got a 6-hour duration. You're going to do surgery. I know you're going to do surgery, but I would suggest that you don't give a spinal or an epidural. Yeah. Because surgery, you can always stop bleeding with cautery or something, but you can't do anything.
Yes, sir. So there is one more query by Gurudat sir. Sir wants to know what is the minimum hemoglobin level for cardiac patient to accept for non-cardiac surgery?
Yes.
Minimum hemoglobin level, sir.
Well,
for cardiac
usually
patients.
it should be at least 9 to 10.
Okay, sir.
No, because
Yeah, but again, it depends. It also depends on the patient. You should get a good hemoglobin level of at least 9 to 10. If you got time, you give intravenous iron. If you don't have time, you can give spectals.
Okay, sir.
Because many of the guidelines say that
I'm just going for a code blue. Sorry, madam.
Okay.
Okay, sir. Okay, sir.
Let
No
him
problem.
go. Let him go. Yeah.
Okay, sir. Thank you, sir. Thank you.
Thank you, sir.
So, Gurudat sir, please continue, sir. Your views.
No, to the extent we are going to, sir can continue the discussion.
Yes, sir.
So it's a matter of the type of surgery and oxygen supply demand ratio being maintained. So that would be the way we discuss, sir. Guru sir, about the hemoglobin.
Majority of the books also and the guidelines say that as far as the minimum hemoglobin is concerned is 8 grams, because even in ICU patients, what they have found is when they have transfused patients, when they had a hemoglobin of 8 grams, brought the hemoglobin to about 10 grams, the mortality actually increased in the hospital. In hospital days, number of days, ICU days were also increased. So that's how, majority of the people say that if hemoglobin level is 8, so if you have time, of course, you can definitely give iron preparation or nutrition, suppose if it is an iron deficiency anemia, and then, or if it is other deficiencies, you can give, treat the deficiency and then bring the hemoglobin to about 10 and then take up, but no blood transfusions. That is what is most important thing. Even if the hemoglobin does not improve above 8 grams, and then you can still accept the patient, but don't give transfusions as a preparation of the patient for surgery. You can definitely use other methods to decrease the blood loss intraoperatively and also keep packed cells ready. If required, you can always give. But that is the one very important thing. Anything above 8 grams, no transfusions as a preparation for the patient.
So for geriatric patients, for some ortho surgery like
Correct.
fracture femur
Correct.
with IHD,
Even
it works
whatever may be
for
this
them
thing,
also.
8 grams, yeah, is the usual. And also clinically, you'll have to assess the patient. It is not just always, this is one of the, cutoff hemoglobins for blood transfusion. It is always there. But clinically, you should always see the patient. Suppose if the patient is having a lot of symptoms of anemia, because of anemia itself, even with 8 grams, so then you may have to rethink. But otherwise, majority of our patients with chronic anemia with even 6 grams, they are not, majority of them are not, symptomatic. So one need not have to. That is what 8 grams is the minimum cutoff. And even for non-cardiac patients, it is 7 grams. That is very clear, actually.
Okay.
The only thing is other factors, as you say, sir.
Yes.
For example, the patient with history of failure and the patient being on anti-failure treatment. So there is always scope for more conservative management in terms of volumes and possible use of blood. It should not result in a fluid overload and the patient who is very balanced. It could not trip in favor of failure. So when we say cardiac disease, it's not just a ischemic heart disease per se. And ischemic heart disease associated with, for example, history of failure, patient on active treatment. So these are the things which must come into picture. And when you say ischemic patient for fracture femur, yeah, so that's what is one of the common scenarios. Generally, they are AHT patients. They are already on anticoagulants. So
Correct.
calculations would be related to a fine balance between, as you say, 8 grams, yes, but we will not be using whole blood. As you say, packed cells will be more beneficial. And it's also a matter of not overloading, and it's a balance with using vasopressors also.
No, but you keep ready. That is what I'm telling.
Yeah.
It is not as a preparation, don't give.
Yeah.
Don't use transfusions. Let it be any, as you are telling about nowadays we don't use whole blood at all. We use only the packed cells. Even packed cells, you just keep it as a reserve. If the patient bleeds, for example, now as you were telling about fractures, if the fractures can be done under tourniquet, absolutely there won't be any requirement. But hip fractures, you cannot apply tourniquet. There is going to be bleeding, and you try to use a regional anesthesia. Definitely, some amount of hypotension that will reduce the blood loss. Plus, you are using tranexamic acid at least about 500 milligrams or 1 gram, just about maybe about half an hour before the surgery. That is also going to reduce the amount of blood loss. So, but in spite of that, if the patient is bleeding intraoperatively, definitely you don't withhold blood, you transfuse. That is what you'll have to see how much of hypotension or hemodynamically, whether the patient is becoming unstable. So, definitely blood transfusion or packed cell transfusion, you have to do it. But as a preparation, I am telling about. As a preparation, don't try to unnecessarily transfuse because there are so many risks of transfusion. Lot of risks. That is what everybody says, that you see the patient as a whole, see his condition also, and then you decide. But as a guideline, it is you better prevent blood transfusion as far as possible as a preparation. Even for patients with chronic kidney disease also. We were accepting these patients even at 6 grams without transfusion before. Now we give erythropoietin for them or darbepoetin and bring the hemoglobin to 10 to 11 grams, 11 grams per deciliter, and then only we are taking up, because now the minimum hemoglobin for these patients for elective surgery, you can even bring them up to 11 grams, not more than that. Because anything more than 11 grams in these chronic kidney disease patients, they can have a resistant hypertension, and also they are more prone for thromboembolic phenomenon because the viscosity of the blood should not be increased so much. So you gradually improve the hemoglobin, because even when you give erythropoietin, you're going to increase the hemoglobin level by 1 gram every month. So if it is an elective surgery where it can be, it can wait for 4 months, you can bring the hemoglobin to 11 grams and then take up. But no transfusion. In chronic kidney disease, who are probably be taken up later for renal transplant surgery, there is no point in giving them blood transfusion and then producing HL antigen problems also.
Probably.
So in general, so wait, don't, we have seen in where all the hospitals we have worked, the surgeons themselves would have transfused already if
Yeah,
the
that's the
patient.
thing. That's the problem I was trying to convey. Especially trauma and these fracture femur cases, there is a tendency among the surgeons to pre-transfuse.
Yeah, that is
Even
what is
if we
the
give advice.
correct. That
But
is
again,
not
we are at the receiving end.
uh,
In the OT, we are the ones who are expected to manage.
correct.
Yes, sir.
Nowadays, most of the procedures are closed procedures, not extensive dissection. So even the need for blood transfusion also will be less.
Now, even intraoperatively, it is said that
Yeah.
till hemoglobin drops down to 8 grams, there is no need for transfusion. That's how when they have introduced this non-invasive measurement of hemoglobin by pulse oximetry. So that is how one of the sentence that has been given in that particular article I had read about the recent advances regarding the pulse oximetry is that so many blood transfusions intraoperatively have been prevented, because continuously you are monitoring the non-invasively the hemoglobin level, and unless the hemoglobin level drops down to 8, you need not have to transfuse even intraoperatively. So that thing is always there.
Next question.
Yes, sir. Balakrishna wants to know the tranexamic acid, whether it is safe for major non-cardiac surgery, status post PTCA.
Sir, Gurudat sir,
Tranexamic acid.
take the questions.
Yeah.
No, there are a few contraindications for, of course, tranexamic acid, especially the patients who have had a cerebrovascular incident, if they have had a stroke, if they have got TIAs. So, and geriatric patients, you will have to, risk benefit ratio, you'll have to see. The risk of bleeding, if it is too much, then definitely you transfuse. And if the benefit of not not giving tranexamic acid, definitely you have to weigh the risk and benefit, and then you have to decide. But in patients who are geriatric patients, and if if they have had previously the strokes, then I think you may have to think twice before giving tranexamic acid, because it can increase thromboembolic phenomenon.
Yes, sir. Thank you, sir. So, PG, Dr. Mahatesh Kumar, he wants to know any specific predictors of MACE in pregnant patients posted for elective or emergency LSCS.
Specific?
Predictors of MACE, sir, major adverse cardiac events.
No. Specific what major adverse?
Predictors of MACE in pregnant patients posted for LSCS, sir, elective or emergency.
Assuming that the patient is a cardiac upsick patient.
The CARPREG score is there, but CARPREG score does not say the incidence of major adverse cardiac events. CARPREG score is mainly for pregnant patients with cardiac disease posted for either cesarean sections or any other non-cardiac surgery. So it doesn't say the incidence of major adverse cardiac events, but it says that the risk of, probably the mortality risk, it gives more importance there as far as CARPREG score is concerned. But the same, whatever the other scores are there, you can apply for pregnant patients as well. And majority of the pregnant patients, either they may have a valvular heart diseases or a congenital heart diseases, or they may have, cardiomyopathy. These are few of the cardiac diseases these pregnant patients may have, peripartum cardiomyopathy. So naturally, there are no. I am for as far as my knowledge goes, there are no separate scoring for MACE there. If Bhaskar knows, probably he
No, I
may.
don't remember being a separate score as part of the AHA guidelines even recently published. So only thing is all of us should keep in mind that the cardiovascular changes are per se part of a pregnancy. And as you say, sir, they are more prone if there is a background of hypertensive disorders, preeclampsia, eclampsia group of patients. That's always one factor that we have to consider. And still, there are isolated reports of the valvular heart diseases. So they can decompensate, especially during delivery and cesarean section. So these things are
Especially peripartum cardiomyopathy.
cardiomyopathy is very
That's
dangerous.
one of the most dangerous, because invariably these patients will be in failure. So then, as such, already they are in failure and they are on treatment with failure. And naturally, those patients will be at high risk of developing major adverse cardiac events, including cardiac arrest, pulmonary edema, cardiac arrest.
That issue is always there.
Yeah.
Yes, sir. So the role of permissive hypotension in preventing blood loss, sir, in major non-cardiac surgeries after PTCA.
Now, we know that after PTCA means the patient is having coronary artery disease. So in any patient with coronary artery disease, you have to maintain the diastolic blood pressure. So diastolic blood pressure minus left ventricular end-diastolic pressure is the coronary perfusion pressure. So it is very important that you maintain the diastolic pressure, blood pressure. So now majority of the advisories and guidelines, they say that whatever their blood pressure is there, see that the blood pressure, lower blood pressure or higher blood pressure is around 20%. In that range, do not reduce the blood pressure more than 20%, or do not see that the higher blood pressure that occurs intraoperatively is not more than 20% higher than their basal blood pressure. So that as long as you maintain that range of blood pressure, 20% this side and 20% that side, there should not be any problem. So you can keep a blood pressure around 20% lesser than their basal blood pressure, not less than 20%. Because coronary perfusion pressure is the most important thing you have to maintain. And in a patient who is a known coronary artery disease patient.
But when Dr. Balkrishna is asking about permissive hypotension, basically, before speaking about the vasoactive drugs, vasodilators and other things, I think we can always nowadays speak about the use of dexmedetomidine. He must be using regularly, Balkrishna. It's sort of, in a patient who is awake, for example, on regional anesthesia, or a patient who is under general anesthesia, administration of dexmedetomidine has been associated with a relatively stable blood pressure. So apart from being an analgesic, all of us know this alpha agonism produces a very stable heart rate, especially, which we are bothered about in ischemic heart disease patients, and of course with monitoring. I think it's one of the drugs I thought I can ask. It may not be part of the guideline with Dr. Divatia. So there should be a good role for dexmedetomidine, sir.
Yeah, it is a real wonder drug, definitely. Dexmedetomidine, only problem is severe
Properly used.
drowsiness it can produce
Yeah.
in awake patients. That is one problem. And the other thing is for preventing the sympathetic response to laryngoscopy in intubation, definitely it is one of the very good drugs. But intraoperatively, to continue it as an infusion, like for example, now you can continue with dexmedetomidine 0.02 to 0.05 micrograms per kg per minute. But that you have to think.
Yeah, that's
But
what we must monitor. Definitely.
Yeah, single dose 1 mic per kg body weight, what we use 10 minutes before or 15 minutes before as an infusion as a pre-induction drug. So that definitely it is one of the very good drugs. And it also has got a lot of organoprotective functions also. So that is an advantage, whether it is a brain or kidneys. Even it has been found that it is going to prevent acute kidney injury in the postoperative period. intraoperative and postoperative period. That also has been found specifically with dexmedetomidine. So one can use, but again, see that the blood pressure does not drop more than 20%.
Yeah.
That you should always keep.
Yeah, very important. I mean, very dangerous drug also to administer and follow up. So our people, we should not become complacent when we use dexmedetomidine. It's very important. Very good drug, but
yes,
must monitor.
So regarding bridging therapy, sir, should we still continue the conventional unfractured heparin, or is there any role of newer oral anticoagulants?
So for bridging therapy, no role for heparin, because heparin is entirely a different kind of drugs and antiplatelet drugs are entirely different kind of drugs. So that you should always remember. So that is the reason why Dr. Divatia was also talking about Cangrelor. Cangrelor is definitely an antiplatelet drug. So that's why there is no role, because heparin is an anticoagulant drug. Whether it is a low molecular weight heparin or unfractionated heparin, they are all anticoagulants. There is no role for anticoagulants to bridge. If you want to bridge, you bridge with an antiplatelet. So that's how IV antiplatelet drug Cangrelor, because why Cangrelor? There are other drugs are also there, but the main problem with other drugs, their half-life is quite prolonged, almost 12 to 18 hours half-life is there. But Cangrelor half-life is 60 minutes to 90 minutes, very short half-life. So that's how you can use Cangrelor and stop it about 1 hour before and then take up the patient for surgery. No role for heparin as a bridging agent. I don't know, Bhaskar can.
No, that's perfect, sir.
Yeah.
That's the reason it should be part of our correct preparation in the preoperative period.
Correct.
So you follow the basic recommendations of stopping the drug, and when you think about basically the actual indication, whether the patient was on both antiplatelets or anticoagulants, the dual antiplatelet therapy plus an anticoagulant, depending upon the indication. So we have to weigh the indications and the possible risks of stopping the particular drug and starting on a different class of drug. So that's also possible in some set of patients. So that's all left to
only probably when you would like to use Cangrelor as a bridging therapy is, suppose a patient has had a the stent done maybe 1 month before, and then he has to be taken up for a time-sensitive surgery, and the stent has been placed when he had an acute coronary syndrome. Usually when you place a stent for acute coronary syndrome, especially the drug-eluting stent, ideally speaking, you have to wait for 6 months before taking up for any kind of elective procedure. Other surgeons, if the patient has been placed with a drug-eluting stent when he did not have a acute coronary syndrome, you can even take up the patient after 3 months. You can stop one drug and you can continue with aspirin. But for acute coronary syndrome, it is very important because there is every chance that these patients, if the antiplatelet, dual antiplatelet therapy is stopped, they are highly likely to go for stent thrombosis. So in such patients, if you cannot postpone the surgery, you can take them up with a bridging therapy. That is a rare case, probably. Otherwise, routinely, we don't bridge. I don't know how many times you people have given Cangrelor and taken up the patient anytime in your experience. At least in my experience, not had. But that's a rare case.
Not familiar with the drug, and at this point of time, practically speaking, suppose the cost.
Cangrelor is a regular drug that is being used for cardiac surgery.
Yeah.
They are routinely using, and not only cardiac surgery, for stenting also.
Yeah.
They continue to use Cangrelor intraoperatively also, and during the procedures also.
Yeah.
So, but as non-cardiac anesthesiologist, we are not familiar with Cangrelor and other drugs.
No, when we are not that familiar, means we have not come across such a really important thing for such situations in practice.
Such situations, correct.
So,
The next question is the induction technique in case of heart failure and low ejection fraction scenarios, sir.
There are, there are two techniques that are there. It depends on whether the patient is posted for cardiac surgery or non-cardiac surgery. So if the patient is being posted for cardiac surgery with low ejection fraction and patient may be in failure and all, so high dose opioid with benzodiazepines, that is the ideal thing, and they're routinely, even now they are using, especially, fentanyl about 20-25 micrograms per kg body weight and midazolam 0.1 to 0.15 milligram per kg body weight. That can be used because majority of these patients require postoperative mechanical ventilation. You are not bothered about the high dose of fentanyl you are giving. Otherwise, etomidate is the drug of choice. If the patient is posted for non-cardiac surgery and you have to take up the patient in spite of patient having all these problems. Otherwise, ideal would be to defer the surgery, optimize the condition of the patient, and then only take up. There is no point in taking up the patient when the patient has got so low ejection fraction and also is in failure, decompensated failure. So you have to postpone, you have to, optimize the condition, and then only you may have to take up. Otherwise,
Yes.
etomidate is always there. Before etomidate, we had a lot of problems.
Yeah.
Like people also have used to use propofol with ketamine. Ketofol also people have used, but it is better to go for etomidate because it is an absolute cardiostable drug. So no problem.
Yes, sir. So new onset of atrial fibrillation on the day of surgery, sir, in case of fracture neck of femur in a patient. So when we can go ahead with the case?
The new onset of atrial fibrillation, because fractures as such, especially fracture hip, is considered to be an urgent surgery. So if you postpone for, it is said that if you postpone for more than 48 hours, there is always risk of mortality and risk of complications for these patients. The majority of them are geriatric patients. And if the patient has developed an atrial fibrillation, you control the rate and take up. It depends. What is the cause for atrial fibrillation? So if the atrial fibrillation cause is because of some, geriatrics itself is one of the cause for atrial fibrillation. And second thing is, hypertension is one of the causes for atrial fibrillation. And most common cause is, mitral valvular heart disease and thyrotoxicosis. These two are the most common cause. Other than these, hypertension and,
Geriatric.
old age. These are other causes. So if it is because of old age or because of hypertension, you control the rate, because there are two methods for how you manage atrial fibrillation: rate control or rhythm control. So you can try for rhythm control using amiodarone, provided the patient is hemodynamically stable. If the patient is not hemodynamically stable, definitely you may have to go for a cardioversion with atrial fibrillation. Otherwise, if it is cannot be possible for these, you control the rate and make the patient hemodynamically stable, and you can take up the patient as early as possible whenever the patient has got a hip fracture. You cannot postpone for long.
Yes, sir.
Bhaskar, any other input you want to?
Yeah. So
No, for AF, suddenly on the day, I have had one case like that.
it's
On the day
only
of surgery, the
Yeah.
patient was actually posted for, gastrojejunostomy. This I am talking about, say 15 years back. On the day morning, when I went and then looked up, examined the patient, patient had irregular pulse, and I got an ECG done. He had AF. So we started him on, he was hemodynamically stable. He was not, even from his face also, we were not finding any change. Even blood pressures, everything was normal. So we actually put him on the cardiologist. I consulted the cardiologist. Cardiologist put him on two drugs, beta blockers and amiodarone. And the next day only, we took him up for surgery, managed him well. There was no problem. But only other important thing is charts was scoring also, you have to do it. Charts was scoring, if it is more than 3, because many of these patients may require even anticoagulants. So that you may think once, if the urgent surgery is over, then you may have to think about putting them on anticoagulant therapy also. Because usually first 48 hours after developing atrial fibrillation, there is no problem of thromboembolic problem. Usually it occurs after 48 hours. So get the surgery done, and you can always put the patient on anticoagulant therapy. If Charts-Was score, I think everybody is familiar with Charts-Was score, especially for atrial fibrillation. To put them on anticoagulant therapy or not, we use this. Congestive heart failure, hypertension, diabetes mellitus, age more than 75 years is 2 points is given, and stroke, history of stroke, again 2 points. VAS is vascular disease the patient has got. A is age less than 65, more than 65 to 75 years. This is added later. And if the female patient, the patient is a female patient, that is VASC. So that if it is more than 3, definitely these patients may require to be on anticoagulant therapy, because high risk of stroke in these patients.
So we had a similar case, sir, in our RICU, sir, some 2 months back. A male patient with a CA mid-esophagus, sir, he was subjected for transthoracic esophagectomy, sir. So after 2 days in RICU itself, he had atrial fibrillation, sir. He was totally asymptomatic and he was stable, sir. So the
Preoperatively
cardiologist,
or postoperatively?
no, sir, postoperatively after 48 hours, sir.
Oh, postoperatively. Okay.
Postoperatively in RICU, sir.
Okay.
He was stable and totally asymptomatic, sir. Then a cardiologist was called. He did bedside echo and all. It was absolutely normal. Then we thought, and the 2 drains were put, sir. So we thought, like from the surgeon side, the concern was on the other side. On one side, the drain length inside the mediastinum was too much deep, sir.
Oh, maybe.
So maybe it's a factor. So he pulled it, sir. He pulled it, and after I think a few hours, gradually it came down. But
Okay.
again, it reappeared, sir. On the same night, it reappeared. And again, on the advice of cardiologist, amiodarone infusion was started, sir.
Yeah. You may have to.
And it got, yes, sir, it got settled after some 4 to 5 days, sir. And gradually, amiodarone was also stopped, sir. Yes.
No, because amiodarone is the drug which can produce pharmacological cardioversion.
Yes, sir.
All other drugs like beta blockers or calcium, they only can have a rate control.
Yes.
And rate control is also fine for many of these patients. We just put them on. Digoxin was one of the common drugs that was used in India before, but because of digoxin having low therapeutic index, so we don't use digoxin much. So other drugs are there. Beta blockers, one of the best drugs for rate control.
Yes. So there is one case scenario by Dr. Anjana, sir. There was a cardiac arrest in elderly primate around 40 years who was in 36 weeks of gestation with gestational hypertension under control. And she was on antiplatelets with low molecular weight heparin till 35 weeks. She had a sudden cardiac arrest on the day before planned cesarean following chest discomfort, although immediately initiated resuscitation could not save her. But on PM, it was revealed that she had massive MI. So she wants to know whether ECG and 2D echo mandatory in such high-risk obstetric cases,
No,
preoperatively.
ECG and 2D echo may be even normal before a patient develops a myocardial infarction. So that will not give you any indication that the patient may develop a myocardial infarction or anything, unless the blood pressure has not been properly controlled regarding the preeclampsia, or the patient may also have cardiomyopathy, because in these preeclamptic mothers, peripartum cardiomyopathy is also one of the common complications. So if such is the case is there, then preoperative echo would tell us whether the patient has peripartum cardiomyopathy. Otherwise, it may not give any indication of patient developing a myocardial infarction. I don't think. Even ECG may be normal in these patients, and afterwards suddenly they may develop, because these patients are highly prone, especially I don't know what anesthesia was given for that patient, and they may develop an MI or even a stroke when we are doing a laryngoscopy in intubation, because it's one of the most important or most stressful stimulus, which can shoot up the blood pressure and heart rate, and the amount of stress they develop either for the heart or the brain, invariably they may develop an myocardial infarction. So that is one very important thing which you have to look into if we are giving general anesthesia for the patient.
This is a preoperative death, she says. But one thing is fertility workup patient. I think there will be a lot of hormones. That would be one of the contributing factors in this particular case. That happened.
No, such patients are the one who develop even preeclamptic toxemia also.
Yeah.
ET is very common, and severe features.
Severe
ET with severe features is very common in these particular women, elderly with who are on multiple hormonal therapy for pregnancy. Definitely they are prone.
The lady has been put on antiplatelets and low molecular with heparin, sir.
Now, why low
Why it
molecular
was
heparin? Probably for DVT prevention, she would be on. And now, usually aspirin is one of the drugs that is always used to prevent preeclampsia. Many times, even from the second trimester, starting of the second trimester, once organogenesis is there, is completed, that is usually the first trimester. From the second trimester, majority of these patients are put on aspirin nowadays, which is going to decrease the incidence of severity or even decreases the occurrence of preeclampsia in these high risk mothers. But why dual antiplatelet therapy, I don't know.
No, heparin, sir.
Yes, sir.
Low molecular heparin.
Low molecular heparin with dual antiplatelet therapy. That
With
is
antiplatelets. With
antiplatelet
antiplatelets.
is only aspirin or dual antiplatelet.
Yes, it's not clear.
If it is only aspirin, usually they'll be put on aspirin from
Yes,
the second trimester.
It is only aspirin.
Low dose aspirin, 75 milligrams, is commonly used.
Commonly.
Majority of high risk pregnancy patients.
So there is one more query by Dr. Baswaraj. A cardiac patient for non-cardiac surgery was planned under central neurological blockade. What is the time to resume anticoagulant medication in postoperative period with central neurological catheter in situ?
Oh, that is what giving epidural sticks through the epidural catheter, and you can start afterward. Ideal would be 24 hours, depending on the risk of a patient developing thromboembolic phenomenon. If you think that there is a high risk, you can even start after 6 hours. If it is the patient is being given a prophylactic dose of low molecular heparin therapy, and if the patient is on warfarin, usually we stop warfarin about 5 days before and put them on therapeutic dose of low molecular heparin after 48 hours, depending on whatever is the INR. Once the INR comes down to less than 1.5, you can start them on low molecular heparin, depending on whether the patient is high risk for thromboembolic phenomenon or not. If the patient is not at high risk of thromboembolic phenomenon, you need not have to bridge with low molecular heparin. So then you start warfarin after 24 hours only, after the surgery. Oral warfarin, you can restart. So because you have stopped warfarin for 5 days and then you can restart. So that is definite guidelines are there. ASRA guidelines are there. One can go through very clear about these things. Heparins or even oral anticoagulants, whether to restart, when to stop, everything is there. But if it is a therapeutic dose, you cannot keep the catheter when you want to restart heparin, low mercury heparin, you have to take out the catheter and then wait for 4 hours and then you can restart.
Yes, sir. So, Dr.
All the
Madan
new
Katosh
guidelines,
wants to know.
just to interrupt, all the new guidelines speak about high dose and low dose. They don't talk about prophylactic dose and therapeutic dose.
Almost the same.
Yeah, terminologies they have changed, sir.
Okay.
Not just terminologies also they have changed officially.
Correct. Because what I'm telling is 2020 ASRA guidelines.
Yeah.
In that still it is there, probably later.
Okay.
Yes. So, there are any guidelines for the calculation of MET score for risk stratification in non-cardiac surgery, sir?
No, because actually MET scoring means you have to, ideally speaking, you have to go for Duke activities status index. So Duke's activity status index, that is DASI, then a lot of questionnaire is there, and then you have to ask all these questions. For every question there is a scoring is there, and finally there is a formula to convert that DASI scoring into METs. So you can easily convert it into METs from that. Otherwise, normally what we usually use, if the patient can climb 2 flights of stairs or 3 flights of stairs or even 1 flight of stairs, if he can climb without becoming breathless or without getting an angina, so you can say that he has got around 4 METs.
Okay, sir. Thank you, sir.
Yeah, they are all available in the MD Calc app. So I think actually we are under-replacing it. So youngsters should know and they should start using the MD Calc app, which is available for many of these.
This DASI scoring, this thing is there. Duke activity scoring index is definitely is there.
Yeah.
So the concern about continuing or stopping the nitroglycerin, sir, on the day of surgery in case of post-CABG patient with some risks like diabetic, hypertensive, who will be on multiple drugs like beta blockers, calcium channel blockers, diuretics, dual antiplatelets and all. So the role of continuing or stopping the nitroglycerin, sir, on the day of surgery.
Nitroglycerin means oral nitrates.
Yes, sir.
So
oral nitrates, sir.
Yeah, oral nitrates you continue on the, because only few drugs we stop on the day of surgery, like ACA inhibitors or ARBs. You'll have to think twice whether to continue or not. It all depends on whether they have been given for antihypertensives or for anti-failure drugs. If they are given for failure, just now Dr. Divatia was talking about that you can continue on the day of surgery, even AC inhibitors or ARBs. But if they are being used for hypertension therapy, you may have to stop on the day of surgery. So, but nitrates, definitely they have got a good role, you can continue. But only thing is when the patient has been given nitrates, the interaction with our IV induction agents and inhalation agents, there is going to be a drop in the blood pressure. So this you have to keep it in mind, because nitrates are also venodilators. Basically, when we give therapeutic dose of nitrates, they're basically venodilators. They decrease the left ventricular end-diastolic pressure. They do not have much effect on diastolic pressure. That's how coronary perfusion pressure is maintained with the therapeutic dose of nitrates. So you continue with nitrates on the day of surgery. There is no scope for stopping nitrates on the day of surgery. Very few drugs we stop, like the SGLT2 inhibitors. Nowadays we stop 3 days before. That also is there in the guidelines because they can produce euglycemic diabetic ketoacidosis. One problem. Second problem, they can also produce severe hypovolemia. So we don't want any patient with hypovolemia on the day of surgery. That's why we usually stop SGLT2 inhibitors at least 3 days before. And DPP4 inhibitors, you continue even on the day of surgery, there is no problem at all. That there is no problem. GLP-1 agonists, they say that you may have to stop even 1 week before. So these are few of the things regarding the anti-diabetics, but majority of the other drugs we continue on the day of surgery. Diuretics, again, loop diuretics, 1 day before you may have to stop. And you do electrolyte studies, and also postural hypotension is there or not, you check, because loop diuretics can produce, hypolemia. Whereas thiazide diuretics, you need not have to stop if they have been given more than 1 week, because the basic effect of thiazide diuretics will be, vasodilatation rather than diuretic effect after 1 week. So you continue even thiazide diuretics on the day of surgery.
No more questions, sir, in the chat box.
So thank you, sir. But you could join only late.
But
sir.
actually,
You were not there early.
huh?
You joined late, sir. You were not able to join early.
No, actually, I had gone out. I'm in Bangalore, actually. I'm in my
Okay.
son's place. Actually, every Friday, Saturday is my classes, actually, between 5 and 7.
Okay.
Online classes.
Oh, thank you.
So today, actually, I canceled my class because you had given this message.
Yeah.
So
Thank you, sir. Join ಆಗಿದ್ದು ಒಳ್ಳೆದಾಯ್ತು. It was good. We joined. Divatia sir had to go for some emergency.
Bhaskar is there, you are there.
For him.
Yeah.
He had to rush.
You can't help it. That is one of the problems.
Yeah, that is there.
Correct.
And the two sorry is in critical care.
So shall we conclude, sir? Okay, sir. Sir,
I could see all of you.
Yes.
Thank you so much, sir, for bridging, sir, for bridging the gap very much effectively with your extensive knowledge, sir.
With Congress.
Thank you, sir. Thank you very much.
Thank you.
And I thank all the participants, Bhaskar sir and Srinivas sir.
Dr. Divatia, the speaker, the 50th speaker. So,
Yes,
our Anaesthesia Society.
Yes, sir.
And our.
But Dr. Bhaskar, this thing has been given, the subject is intraoperative complications in cardiac patients, isn't it? That is what I thought.
Major adverse cardiac events after non-cardiac surgery, sir.
Major adverse cardiac events after non-cardiac surgery.
Non-cardiac surgery.
I was thinking that Dr. Divatia would be talking about the complications that occur intraoperatively and after his pre-anesthetic evaluation.
Overall cardiac events, major cardiac.
Use the guidelines as a base and discussed it.
Yeah, he would have continued about the intraoperative major adverse cardiac events, how to prevent.
We have discussed also, as you say.
Yeah, but unfortunately he had to leave in between and had to go.
Yes, sir.
Yeah.
So thank you, sir.
Thank you, sir. Thank you.